So good afternoon, everyone. Welcome to this session. For those of you who are reading the program in detail, you would have expected Darren Maguire to be standing here. I am obviously not Darren Maguire, but he sends his regrets for not being able to come to chair this session today. I'm Alice Chang. I'm an endocrinologist from the University of Toronto, and it's my pleasure to step in to chair this symposium. I was going to start off by saying we have a wonderful lineup of speakers, and then I realized I'm one of the speakers, so I perhaps should not say that. But we do have a wonderful lineup of speakers to discuss this very important topic of diabetes and peripheral arterial disease, the evolving role of GLP-1 receptor agonists, and new insights from the STRIDE trial, which came out in March of this year and certainly has a very important role to play in the diabetes space and for us as endocrinologists and diabetologists. So this is also a very much of an all-Canadian lineup with the exception of Nita, but we can adopt you into Canada anytime that you want. So we've got exceptional speakers. We're going to be starting off with Dr. Zaina Al-Balawi, who's an endocrinologist from Canada, and she will show you in her title slide where it is that she works. But most importantly, she literally had a baby 2 weeks ago. And she's here. So she is going to give us a fabulous talk looking at diabetes and PAD, epidemiology and clinical consequences. And then we are going to hear, what's the sequence? And then we're going to hear from Dr. Subodh Verma, who is a cardiovascular surgeon and a real leader in the cardiometabolic space in terms of clinical trials and just being a thought leader in the entire field. And he's going to be speaking about the rationale and the key results from the STRIDE trial. And then we're going to hear from Dr. Nita Rasuli, who is an endocrinologist, a significant player within the STRIDE study as well from Colorado, University of Colorado. And then you have to hear me come back, and I'm going to talk about the implications from an endocrinologist perspective. So having done that, I'm not going to step up between each of the speakers. We'll just take turns, and then at the very end, we will have some time for Q&A. So with that, it's my pleasure to bring to the stage the lady who had a baby 2 weeks ago. Again, she needs another round of applause for showing up. Dr. Zaina Al-Balawi.
Thank you. Thank you very much. And it's an absolute pleasure to be here today. This is a topic that I'm quite passionate about, so I was quite thrilled to get the invitation and join the stellar panel here. So we'll start with setting the stage before we dive into the STRIDE trial. And we'll take a look at the big picture on what the landscape looks like for those individuals living with diabetes, but also having concomitant peripheral arterial disease. And you'll get an idea why it's really important to highlight this, because the literature was quite scarce in terms of delineating and clarifying that relationship and how the comorbidities, mortality and morbidity, is unique to this population compared to those with diabetes only or peripheral arterial disease alone. And so I work at Memorial University on the most eastern point in North America, in St. John's, Newfoundland and Labrador. And I've been involved in quite a bit of work with clinical guidelines nationally and internationally within this field, the most recent being Canadian Cardiovascular Society. I have no financial or intellectual particular conflicts relating to this topic. And the key objective is really to summarize the current epidemiological data on diabetes and peripheral arterial disease. So let's just start with some similarities and a number of overlap between those two conditions, peripheral arterial disease and type 2 diabetes. And we know that over the past several years and predicted over the upcoming years, these two conditions do pose a growing public health concern worldwide. And there's an increase in incidence anticipated over the upcoming years. There are a number of shared factors between those two conditions. So we see age as well as elevated lipids, but we also have some unique ones for peripheral arterial disease like smoking and some of the common cardiovascular risk factors. Looking at type 2 diabetes, we're aware about the genetic predisposition, family history, environmental, as well as a pre-existing diagnosis of prediabetes and gestational diabetes. Peripheral arterial disease has a preclinical state, and so only about 10 to 20% present with the classical claudication. And so even though as we look at this epidemiological data, keeping in mind that there are some challenges in terms of ascertaining that diagnosis, which contributes to a number of heterogeneity, but I think there have been some substantial studies at a population level, which we'll go over in a minute. Type 2 diabetes, when somebody has that diagnosis, they're twice more likely to have peripheral arterial disease. So you can see that kind of vicious cycle interconnected. And ultimately, the most feared complication for people living with diabetes is amputation. And we've seen again and again in the literature that it is feared more than death. And so it really matters to people living with diabetes, and therefore it should matter to us both in the research and clinical realms. Type 2 diabetes is associated with a number of micro and macrovascular complications, and we know that the stepping stone is typically peripheral neuropathy, which then progresses to a diabetes foot ulcer with or without peripheral arterial disease, complicated by an infection, and then the final amputation. So a lovely study. I was just thanking Dr. Verma for conducting the systematic review, looking specifically at the epidemiology and burden of peripheral arterial disease in those with type 2 diabetes. This is one of the largest systematic reviews to date, just published recently in 2024, and it's the most comprehensive, which included about 87 studies touching on epidemiological data as well as other outcomes and person-level outcomes as well. So what did it show? So when we look at cardiovascular morbidity and mortality, there wasn't a meta-analysis just owing to the heterogeneity within those studies. So I'll pick some of the key outcomes related to some of the largest multinational RCTs that were present in this systematic review. So when we look at macrovascular complications, for those with diabetes and peripheral arterial disease, 5-year freedom from major adverse cardiovascular events, or MACE, was 68%. For those with peripheral arterial disease, 68% for those with both those conditions, and compared to 80% freedom from MACE in those without peripheral arterial disease. Looking at mortality, the comorbidities when they coexist, there's a 45% increase in hazard ratio of all-cause mortality, 51% increase in cardiovascular death, and there was also a 32% noted increase in cancer-related death at 5 years for all those 3 mortality outcomes. Health-related quality of life outcomes also show poorer outcomes in those with those 2 conditions. Specifically, and they used various tools, part of it was the Euro Quality of Life -5 questionnaire, and then the VASCU Quality of Life -6 questionnaire, but mainly looking at decreased physical functioning, which is higher in this group, decreased mental and physical health, as well as sleep disturbance contributed relating to the peripheral arterial disease component. Survival rate is also lower in this group. So 5-year survival is 82% for those with diabetes and peripheral arterial disease compared to 91% in those without peripheral arterial disease. Length of stay as well, when we look at an out-of-pocket cost as well as a system or healthcare cost, we see higher utilization of acute care in this group. And the cost from a US study ranged around $52,000 for those with admissions relating to procedural interventions compared to $45,000 for those without peripheral arterial disease. So what percentage are we looking at, and how big of a problem or issue is it? There's quite a bit of variation in the incidence, which is not surprising given some of the reasons I've mentioned. But overall, from 4 of the largest multinational RCTs, the incidence of both those conditions co-occurring is about 12.5 to 22%. So we're looking at about 1 to 2 individuals out of 10 having both type 2 diabetes and peripheral arterial disease. It is no surprise to this audience that diabetes is on the rise internationally, and that when we look at numbers predicted up to 2045, we see that there is some variation in how high the diabetes rates are going to go up. So highest in the continent of Africa and then the Middle East, 134% and 87%. And so it raises the question, well, how are those complications looking? What have we done so far to impact complication rates in those living with diabetes? And just again, to take a step back, we know that the principal goals of diabetes care, number 1, until we have a definitive cure for diabetes, is to reduce the risk of complications, to keep people safe and support self-management. And we recognize that we have both the macrovascular complications, but as well as some of the other complications not fitting within those categories like heart failure, cardiomyopathy, and osteoporosis. So type 2 diabetes contributes to some of the key health outcomes: 30% of strokes, about 40% of cardiovascular events, and about 50% of chronic kidney disease. And the literature shows that over the past years, we've made some significant strides in those outcomes relating to different care models, introduction of various therapeutics. But when we look at lower limb amputations and in those with diabetes, type 2 diabetes contributes the highest, about 70%. To those complications. And I'll show you in a moment when we look internationally, globally, as well as some of the well-done cohort and population level studies, we haven't really made a big dent in this particular outcome, which matters to people living with diabetes. And so international trends in amputation, no surprise, you're going to hear this again, has varied. However, we do see, I've selected some of the studies that had national databases just to give us a bit of a sense of where the direction is. And you can see across Spain and Poland, there's generally been a reported decrease with the time frames showed over here, whereas in Singapore and Austria, there's generally been stability. Of course, you can anticipate that depending how they defined it, what populations they used, there may be some variation. In the US, studies vary depending on which databases, which populations, and what models of care are present. So it's really unclear. Another systematic review, which took a look at a decade worth of data, published not long ago, just a few years ago, showed that yes, there is variation, but overall, we can best estimate that the global incidence is about 94 or 95 cases per 100,000 for lower limb amputations in people with diabetes. And overall, they vary, so we really don't have a clear direction. I'm going to just zoom in into a Canadian study that was done in the province of Ontario, which is one of the largest. But basically, it took all cases of lower limb amputation up to 2016 using a descriptive population-based repeated cross-sectional study to look at the temporal trends and conducted an interrupted time series. I just highlighted some of the definitions to give you an idea of the direction that we're moving in. They used in this study a case-level definition of amputations, which is generally the preferred one because it is thought to be associated and correlates better with morbidity and mortality for this particular outcome. So this means that an individual can be admitted to the hospital, have perhaps an amputation of the toe, and within that same admission have perhaps a below-knee amputation. And so the higher level gets counted. And if we compared to the person level, that's where only an individual contributes a single amputation. So if we only pick up on that big toe and we miss the below knee, you can see how we're missing a core outcome, which is known to be correlated with high mortality at 1, 3, and 5 years. The procedural level is where all comers are counted, and you can see how that can overestimate it. So they took adults over 40 years old, they had 20,000 individuals included, and they had a higher prevalence of type 2 diabetes there. Well, I should say diabetes because the database could not distinguish the types, but 81% had diabetes and 75% had both diabetes and peripheral arterial disease. So quite relevant to the topic and the trial that we're going to discuss today. Major amputations, which is the higher risk, was about 63% in this group. And I'm just going to go through those with diabetes, then those with peripheral arterial disease, and then those with both conditions to look at the trends over that decade and how they've changed. So with the green line, we see that those with diabetes, there was a significant increase in the trends of lower limb amputation over the 10-year period. Similarly for those with peripheral arterial disease, and similarly in those with both diabetes and peripheral arterial disease. It was mainly driven by minor amputations. The major amputations roughly remained stable throughout that period. And in conclusion, at the population level, it seems like, even though we can say stability is great, but recognizing the advancement we have in diabetes care, we would expect to see a decrease in those numbers, particularly with how much it contributes to this serious outcome. So overall, amputations have not declined. Another really well-done study looking at US data from Medicare looked at trends of same thing, both those populations that we're interested in, diabetes and peripheral arterial disease, using US Medicare patients over between 2007 and 2019. And they specifically aimed to identify the long-term survival, pertinent cardiovascular outcomes, and looking at a unique lens, basically touching on regional, racial, and ethnic groups to see if there is any change. It is one of the largest population-based studies, and they had 9 million individuals involved in this analysis who had both diabetes and peripheral arterial disease. So what did it show? Just picking some of the key outcomes that are relevant for today's discussion. A new diagnosis of diabetes and peripheral arterial disease actually decreased over that period of time and in this particular population, but the amputation rates again remained stable. Interestingly, there was an inverse relationship between prevalence of diabetes and peripheral arterial disease and the overall amputation rate. So in areas where there was a lower prevalence of diabetes and PAD, there was actually a higher rate of amputation, and we don't fully understand why. And there are subsequent studies to look into that. And where in areas where there was a higher prevalence, there was actually lower amputation rates. What they also did is they stratified based on race and ethnicity. And when stratified, we noticed that there is a difference. So at 1 year and then 5 years, we see that even though it's small, 1.4% versus 1.9% lower limb amputations, you can see that Native Americans had a higher risk of amputation, so 4.1 to 5% with a relative risk of 1.22. And at 5 years, that persisted as well. 3% versus 3.2%. And you can see in order Native Americans, Black, Hispanic, white, and there wasn't a big difference in the Asian population. So this particular study really highlighted the inequity present, and that just we need to pay attention when we're planning policies, when we're translating evidence or research to make sure that we are addressing the populations that are at most need and understanding those unique patterns in epidemiological data to help us target and then assess for effectiveness. So in conclusion, I hope that I've laid the stage to clarify and to show how both diabetes and peripheral arterial disease are really growing public health concerns that have been increasing over the past years and will continue to do so. And the concomitant presence of diabetes and PAD is associated with higher morbidity, mortality, as well as impaired health-related quality of life. There has been no consistent or sustained decrease in this critical outcome of lower limb amputation rates when we look at other microvascular and macrovascular complications in people living with diabetes. And collectively, I think this puts a compelling case, which we'll hear, which is why I'm really excited about the STRIDE trial and the results that we'll hear next, a need to really address the gap and the impact on health outcomes with disease-modifying interventions for this population. And with that, I thank you for your attention and happy to take any questions when the time comes. Thank you.
Well, good afternoon, and thank you very much to the American Diabetes Association for this opportunity to chat with you about the STRIDE trial. There's a lot of gratitude from the steering committee and the authors for the privilege of the podium to talk about PAD at this meeting. As you know, PAD remains a recalcitrant problem in people living with diabetes for which we've had very few solutions. And I can tell you, most of my work clinically is above the chest as a cardiac surgeon, but I still have sort of very vivid memories of training. And I think the worst thing that I can do, or I did ever, was actually having to perform an amputation and hand a leg over in the operating room. So I think preventing limb loss requires no explanation, right? We need solutions for improving quality of life, quantity of life, and preventing limb loss in PAD, particularly in people living with diabetes. So for that, I think there's a lot of gratitude that Novo Nordisk, who's the sponsor of the STRIDE trial, actually agreed to do a trial in PAD, which is usually unconventional. So the STRIDE trial, as Alice mentioned, was presented a few months ago here in Chicago, at the American College of Cardiology meeting. We published these data simultaneously in The Lancet. And the STRIDE trial was a phase 3B double-blind randomized trial of semaglutide in people with diabetes who also had peripheral arterial disease. And I'll describe exactly what stage of PAD we recruited people in. And I think it actually has laid the foundation for an entirely novel paradigm for GLP-1 receptor agonists as potential strategies in the prevention and treatment of incident and prevalent PAD. You've heard a wonderful presentation by Zaina talking about the recalcitrant nature of PAD, the burgeoning burden that we have. And I think I don't need to remind all of you here as diabetes experts that the type of PAD that occurs anatomically in people living with diabetes is different than people who don't have diabetes. They tend to have more distal disease as opposed to proximal disease of the peripheral arteries, and that makes it less amenable to traditional revascularization modalities. You know, you don't do a fem-pop bypass, and you can't stent many of these individuals because the disease is distal, and therefore they're left with progressive symptoms of worsening claudication with very few interventional or surgical solutions available to them. Now, Zaina has also shown to you data from Ontario, Canada, and this was a study done a few years ago in which we found that, regrettably, over the last decade, from the time we published these data, that lower limb amputations in people living with diabetes were actually on the rise. So despite all of the advances that we are making, we haven't been able to make significant inroads with respect to reducing the burden of peripheral arterial disease globally. Now, when we think about our sort of anti-hyperglycemic pillars today, SGLT2 inhibitors and GLP-1 receptor agonists, we recognize that guidelines such as the ACC and American Heart Association do indeed provide SGLT2 inhibitors and GLP-1 RAs with a class 1 recommendation in people with atherosclerotic cardiovascular disease, which includes people living with PAD. But that priority is not because of any limb-specific outcome per se. That priority is because of an improvement in MACE outcomes. There is only actually one class 1 indicated strategy called cilostazol, which is not available in Canada, by the way. It's available in the United States, that was approved 25 years ago, and that was approved for improving claudication symptoms. But as all of you also know, cilostazol is associated with no cardiovascular benefit per se. It's poorly tolerated, and it's actually contraindicated in heart failure. So, we are really limited by solutions to improve functional outcomes and limit progression in people living with diabetes and PAD. And even the therapy that has been approved a quarter of a century ago is actually associated with a 40-meter improvement in walking distance on a flat surface, which would really be the equivalent of a 20-meter improvement at a 12-degree incline at a fixed speed. And I'll put that in context in the next few minutes. Now, again, I don't need to remind all of our esteemed colleagues today at this meeting about the pleiotropic benefits of GLP-1 receptor agonists and semaglutide, as listed on the right. We know that these are agents that are associated with a reduction in weight and A1C, but they have anti-inflammatory benefits. They improve physical function symptoms. We did a trial called STEP-HFpEF recently that suggested marked improvement in the KCCQ clinical summary score. It is associated with improvement in renal outcomes, and it also, in trials like SELECT, has improved MACE events in people living with overweight or obesity but without diabetes. It improves MACE events in people living with diabetes. So, of course, with all of these wonderful cardiometabolic benefits of GLP-1 receptor agonists, the question that we asked, again, a provocative one, will semaglutide offer symptomatic PAD patients benefits in terms of improving function, improving symptoms, improving hemodynamics, i.e. ankle brachial indices, and will it actually change the trajectory of the natural history of these patients that are identified early with the earliest symptomatic stage of PAD? And I want to really emphasize this, that one of the hallmarks or really salient features of STRIDE is that we identified people at their earliest symptomatic stage with the hope that if we intervene there, that may be the right strategy to actually change their course moving forward. So this was a double-blind randomized controlled trial of people with so-called Fontan 2A claudication, which is defined as sort of one of the earliest symptomatic stages of PAD. Patients were randomized to receive semaglutide at the diabetes dose, 1 milligram once weekly versus placebo for 52 weeks. The inclusion criteria, of course, as I mentioned, included people living with Fontan 2A PAD, defined as a pain-free walking distance of greater than 200 meters, but a maximum walking distance on a constant load treadmill at 12-degree incline at 2.3 miles per hour. That's the standard or the gold standard way for a regulatory path for these studies of less than 600 meters and an ankle brachial index or a toe brachial index of less than 0.9 or 0.7 respectively. The trial had several objectives. The primary objective was the change in maximum walking distance from baseline to week 52 on a constant load treadmill at 12-degree incline and 2.3 miles per hour. We had confirmatory outcomes which included whether or not the benefits persisted 5 weeks after treatment was stopped, i.e. at 57 weeks. We also looked at changes in the vascular quality of life questionnaire. Again, this is a validated questionnaire in PAD. We studied the change in pain-free walking distance from baseline to 52 weeks. We had supportive outcomes and exploratory outcomes, notably a change in ankle brachial indices from baseline to 52 weeks, and then a measure of progression that included major adverse limb events, rescue treatment, as well as all-cause mortality. Now, the other important thing here is that similar to when Dr. Casaboro and the team led the STEP-HFpEF trial, we had a built-in anchor measure. Likewise, here we had a built-in anchor measure to inform us of whether or not the changes that are described are clinically meaningful or not. And that is really the bar, the appropriate bar for studies that are looking at patient-reported outcomes. So I will share that with you as well. So baseline characteristics of the trial are shown here. About 1/3 female, mean age of 68. The trial did not recruit for people living with obesity per se, such that you can see that about 35% had BMIs of less than 27. There were patients who were well treated with background therapy such that blood pressure was well controlled, A1C was 7%, GFR was 53 mils per minute. You can see good background statin use and accordingly LDL control, and no surprises. There was a large majority of them were either current or past smokers. People living with PAD have multiple comorbidities across the cardiovascular spectrum, and therefore this should also not come to you as a surprise that there was a large proportion of people with prevalent coronary heart disease, prior coronary revascularization, myocardial infarction, chronic kidney disease, hypertension, and even heart failure. So let me put this in context. Although we said we recruited people at early Fontan 2A, these patients actually were quite significantly limited in that their ankle brachial indices at baseline were 0.79. But please look at the second column, which is function. Shown here is the maximum walking distance on a constant load treadmill of about 184 meters. What about the pain-free walking distance? About 119 meters. So these are patients that are, again, suffering with significant symptoms of claudication such that if you ask them from a quality of life standpoint at baseline, how would you rate your current limitation in walking ability, 2/3 said moderate to severe in terms of impairment of quality of life. The primary outcome is shown here, and this was the change in maximum walking distance on a constant load treadmill. Again, this is the gold standard for approving therapies in this space. And again, you can see that the curves separated favorably early with semaglutide versus placebo, and using the anchor measure as shown in pink for clinically meaningful improvement, you see an odds ratio of 1.79 with a p-value of 0.002. So this is a clear win for semaglutide in a population of people with diabetes who are not recruited for obesity per se, with the curve separating early in favor of a sort of objective assessment of improvement in maximum walking distance. Now, a 40-meter improvement in maximum walking distance that we see on a constant load treadmill at 12 degrees, on top of standard of care, as shown here, is equivalent to about an 80-meter improvement on a flat surface, just to put that in the context of what we are aware of in the past. Pain-free walking distance, likewise, was significantly improved with the curves separating early. And what was quite remarkable is that even 5 weeks after we stopped therapy, this benefit persisted. So this is not direct proof, but it does suggest that there is a persistent of benefit, i.e. this may be a disease-modifying therapy. The validated vascular quality of life 6 questionnaire was significantly improved with semaglutide, such that when we look at the primary, secondary, and exploratory outcomes for function in yellow, quality of life in green, and most intriguingly, hemodynamics, i.e. ankle brachial indices, this is something that we did not expect, that within 52 weeks we would see an improvement in ABI. This is proof that the therapy is truly a vascular strategy, a vascular medication that has an effect to improve hemodynamics, and that was also improved over 52 weeks with semaglutide. Now, what about the outcome of progression? And, we defined progression in this small trial, again, recognizing, colleagues, that we're starting with people at early stages of the journey in PAD as a composite of, rescue therapy initiation or all-cause mortality. And again, you can see here for that outcome, the hazard ratio is 0.46. Numbers are small, but it still is quite intriguing that we could dramatically alter the natural history of PAD in this population. If you looked at the composite of rescue therapy initiation, all-cause death, or major adverse limb events, including amputation, the hazard ratio there too is 0.46. Now, this is not in isolation, colleagues. You've heard about the FLOW trial, you've heard about the SOUL trial. These are trials of semaglutide in people living with chronic kidney disease or in people with diabetes and risk factors. And there too, the male outcomes were actually consistent or concordant with what I've just shown to you today. In fact, Ron Goldenberg, again from Canada, has recently done a sort of quick meta-analysis looking at all of the GLP-1 RAs and male outcomes, and they do actually point towards a benefit in this regard. So semaglutide in terms of tolerability in the trial was consistent with what we've seen in other trials. And again, I'd like to emphasize to you that this is not just a limb benefit. We already know that in people living with diabetes, there is a MACE benefit to be had. And this is an analysis that we had done a few years ago from the SUSTAIN-6 trial that reminded us that people living with PAD actually are at very high risk of MACE events with diabetes. And in fact, the number needed to treat for a patient with PAD who is given semaglutide is actually much lower compared to the overall cohort. So really, to bring this to a close, the story of semaglutide continues to evolve. It is truly one of not just A1C and weight, but it's a story of the pump, it's the story of the pipes, the filter, sugar, weight, and a lot more. And how we think these things are working remains a mystery. There are the so-called direct effects at the level of the vasculature that are discussed. There are the indirect effects that we're all aware of. Work from our group suggests that they may interfere with vascular regenerative stem cell and the flux between the bone marrow stem cells and vascular repair. And there's a lot more written about how they may be beneficial in people living with PAD with respect to reduction in inflammation, immune activation, macrophage polarization, progenitors, angiogenesis, all of which could then impact oxygen delivery, improved mitochondrial bioenergetics, improved microvascular recruitment that could then be important in PAD. So to summarize, the STRIDE trial in people living with PAD, semaglutide versus placebo, demonstrated an improvement in function. It met clinically meaningful, patient-driven anchor measures of meaningful change. It significantly improved symptoms, reduced disease progression, improved ABI, and the safety was consistent. And therefore, I would suggest that semaglutide now should be strongly considered by our patients living with PAD and diabetes as a strategy to not only improve MACE outcomes, but to also improve functional outcomes in PAD. And of course, we do need more trials of GLP-1RAs in PAD, particularly in people who don't have diabetes. And we need larger trials that will help inform whether MACE or male outcomes are beneficial. But let's learn from our next speaker who was on our steering committee. Netta is going to give you some late, hot off the press news that are going to be published simultaneously to ask the question whether these benefits seen across the spectrum of diabetes, BMI, and other therapies. Thank you.
Hello and good afternoon, friends and colleagues. I'm Neda Rasuli from University of Colorado, but I would like to thank the chair for adopting me to Canada. I might take you on that. But today I'm going to talk about the effect of type 2 diabetes characteristic on semaglutide treatment in people with type 2 diabetes and PAD. And we heard from previous speakers about the prevalence, importance of the early interventions. You may take photos, and here are my disclosures. So as we heard, in type 2 diabetes, PAD is associated with greater functional impairment and higher rate of adverse limb event and amputation. And the reason for that is because diabetes predominantly affects the smaller vessel, as we heard, and this leads to higher chance of lower limb ischemia, amputation, and increased functional impairment. And also people with diabetes have neuropathy that can have negative impact on functional impairment. Unfortunately, functional impairment is under-recognized, but has a significant effect on quality of life. And early diagnosis and intervention could improve functional status and also change disease progression. That's why American Diabetes Association standard of care now recommends screening pre-symptomatic, asymptomatic patient for PAD, for those who are at risk, and defined by age of 65 or older, or people who have microvascular disease or end-stage organ damage, or even consider screening patients with diabetes for more than 10 years duration. And the preferred method of screening is ABI testing. So why we did this subgroup analysis? The question we had was whether this improvement in walking distance or functional capacity is consistent across subgroup of people defined by diabetes characteristic, BMI, and also background medication. We want to know about the diabetes duration because we know that longer duration of diabetes can have a negative effect on vascular disease. So it will be important to see whether they respond differently to semaglutide or not. And also we know that poor glycemic control can have negative effect on ASCVD or PAD. Therefore, it's important to know the response in patients who have poorly controlled diabetes or glycemic versus the one that have A1C at target. BMI is another factor that we looked because we know all semaglutide is associated with weight loss. And stratifying by BMI will give us an opportunity to see whether the beneficial effect of semaglutide was weight dependent or not. We also look at the background medication, specifically SGLT2 inhibitor, because they have cardioprotective effect, and we want to see whether the beneficial effect of semaglutide in the background of SGLT2 was consistent or not, and also looking at insulin use as a marker of long-term diabetes. How we define this subgroup? We define them based on clinically meaningful threshold. For diabetes duration, we chose duration more than 10 years or less. For glycemic control, we chose A1C more than 7% or less than 7% for people who are at target. For obesity, we define them based on a standard definition of BMI more than 30 for obesity and less than 30 for non-obese. And as I mentioned, we looked at the background medication, specifically SGLT2 and insulin use. We analyzed the data from the participant while they were on treatment without the use of rescue treatment or revascularization, and use a mixed model for repeated measures. Let me show you the distribution of participants in each subgroup. The baseline characteristic was shared by Dr. Verma, but I'm going to show you the mean diabetes duration was 13.3 years in the cohort of STRIDE. 39% had a duration of diabetes less than 10 years. And for A1C, the mean was 7.3, and it happened that 44% actually their A1C was at target. Mean BMI was 29.6, and majority of people happened to be non-obese. 59% had BMI less than 30. And relatively a large portion of people, 35% were SGLT2 inhibitor users, and 32% were on insulin treatment at baseline. You heard about eligibility of this STRIDE cohort. They had to meet the Fontaine A class for PAD symptoms. But for us as endocrinologists, this is not a term we use, Fontaine 2A. So I decided to kind of simplify that and explain what they mean. So all of the patients at the screening visit had to walk on the flat treadmill with a fixed speed of 2 miles per hour. And they had to be able to walk at least 200 meters without any pain. So we are talking about early stages of symptom or mild intermittent claudication. To put it in context, if you want to walk a length of the soccer field or football field, that's 100 meters. So these patients are able to walk at least 2 laps of the soccer field without any pain. And then they did another test on the constant load treadmill with an incline of 12%, and the maximum they could walk was 600 meters. That's how we enrolled the patient, and they became eligible for trial. Just to put it into context, the metabolic equivalent or the energy required to walk on that incline of 12% is twice as flat. So that's how Dr. Verma kind of concluded that any improvement in constant load treadmill, you should double it to get an estimate of what is the improvement on the flat surface. The other thing that I would like to also mention, in addition to this criteria for limited walking distance, everybody met the criteria of ABI less than 0.9 and TBI less than 0.7. All of the outcome of the study was measured on constant load treadmill. So when I mentioned increase in maximum walking distance, they're all on the incline of 12%. So let's look at the baseline value for maximum walking distance and pain-free walking distance in different subgroups. As it was mentioned, people in semaglutide in the blue color and also placebo in gray, they had an average of about mean maximum walking distance of 190 meter on constant load treadmill. Pain-free walking distance was roughly around 116 meter. But we are interested in different subgroups, and you will see that there was these subgroups were comparable in regard to maximum walking distance and also pain walking distance. Pain-free walking distance, I apologize. And there was no meaningful distinction between subgroups among these in regard to maximum walking distance or pain-free walking distance. Now I'm gonna show you the changes in maximum walking distance by type 2 diabetes characteristic or among different subgroups. This is the entire cohort. The maximum walking distance ratio to baseline improved in semaglutide more than placebo arm. And here the result on different subgroups. You will see that the effect of semaglutide, the beneficial effect of semaglutide among different subgroups was consistent. Again, ratio is difficult to interpret in the clinical setting. What is the absolute distance improvement? And Dr. Verma mentioned that after semaglutide treatment, there was roughly 40 meter improvement in mean walking distance in entire cohort. And here is what happened in different subgroups. There was consistent beneficial effect of semaglutide on maximum walking distance. They might be numerically a little bit different. That's why we did we call it estimated treatment ratio analysis. This ETR will show us the beneficial effect of semaglutide subtracted from placebo. And the ETR for entire cohort was 1.14. And any number above 1 favoring semaglutide. And you will see underneath all of this red line shows ETR for different subgroups. And it's important to pay attention for P4 interaction. You will see that all of them non-significant, suggesting the consistent effect of semaglutide regardless of type 2 diabetes characteristic for maximum walking distance at week 52. So I'm gonna show you similar result for pain-free walking distance. The improvement in pain-free walking distance in semaglutide was superior to placebo, and we saw the same result in the ratio to baseline for pain-free walking distance among different subgroups. Here are the result or the finding in the absolute distance. Roughly people in semaglutide, they could walk 30 meters more without pain on constant load treadmill. In different subgroups, the effect was consistent, suggesting that beneficial effect of semaglutide on pain-free walking distance was independent on different diabetes characteristics and consistent among all subgroups. Here is ETR for pain-free walking distance, 1.15 for entire cohort, and you will see the number for different subgroups. But the important thing, the P for interaction was non-significant among subgroups, suggesting consistent beneficial effect of semaglutide on pain-free walking distance. So the next question we asked in this subgroup analysis was whether the improvement in functional capacity was dependent on weight loss or glycemic control. So we correlated the change in maximum walking distance with change in BMI or A1C. Here is for entire cohort. The baseline weight for entire cohort was 84 kg, and semaglutide caused 4 kg of weight loss, which is estimated treatment difference of semaglutide over placebo for weight loss. And the correlation was weak in semaglutide or placebo. We are talking about correlation between change in BMI and change in maximum walking distance. But you remember that the large proportion of these people were non-obese. So we decided to look at the same correlation and do the same analysis in the subgroup of obese versus non-obese. As you expect in people who were non-obese, had BMI less than 30, the weight loss was slightly less than obese people. We are talking about ETD of minus 3.6 in BMI less than 30 and ETD of 4.6 weight loss in obese group. But the correlation did not exist. So the change in maximum walking distance did not correlate with change in BMI. We did a similar analysis for A1C. The baseline A1C was 7.3, and the estimated treatment difference for semaglutide versus placebo was 1% reduction in A1C, and there was no correlation in entire cohort. We did a similar analysis in subgroup, and we could not find any correlation between change in A1C and change in maximum walking distance. Next, we look at the safety profile of semaglutide in different subgroup, and the rate of adverse event, serious adverse events, GI disorders, hypoglycemic event was similar across subgroup. More specifically, people who had low BMI or had A1C at target had similar safety profile, and it was comparable to overall cohort. So in conclusion, we showed that in this post hoc analysis, the benefit of semaglutide is independent of baseline diabetes duration, BMI, A1C, and also does not depend on background medication, including SGLT2 inhibitor and insulin. We found the functional benefit didn't seem to correlate with weight loss or glycemic improvement. And this finding supports that semaglutide consistent efficacy and safety profile across the spectrum of type 2 diabetes, including those who are non-obese and they have well-controlled diabetes. I'm excited to announce that this data is being available now online, simultaneously published in Diabetes Care. Thank you.
Okay, so now it's my task to discuss the clinical implications of the STRIDE trial for endocrinologists/diabetologists. And the reason why this is an important topic to discuss is because some people have looked at the STRIDE study and said, well, this is peripheral arterial disease. Does this actually impact my world? And how is this going to change my practice? So hopefully by the end of this, you will have a sense of the approach that you're going to want to take with this. So these are my disclosures, and you are welcome to take photographs. And as an aside, I'm going to say, when you sit up here and you watch as you guys present, you kind of predict which slide is going to cause this to happen. And you can see it. It's like a sea of cameras going up. It's actually quite fun to watch. Okay. So this was the STRIDE trial. So you had the pleasure of listening to the principal investigators and hearing the baseline characteristics, the rationale, the results, and then very excitingly, new data that was presented to us. And I want to begin actually by congratulating the steering committee as well as all of the investigators involved in STRIDE, because you need to remember that STRIDE was conducted in the thick of COVID. It was in the thick of COVID that the study was initiated and a lot of the recruitment happened, and it was a very difficult study, I'm sure, to have completed. So let's give the group a round of applause for having done the study. So just a very quick recap, 792 people living with type 2 diabetes and peripheral arterial disease, defined as Fontaine Class 2A. These were their characteristics, and I'm going to come back to this and highlight some of the key things within this that I think has particular relevance to us. Randomized to get semaglutide 1 milligram once weekly versus placebo, with the primary endpoints looking at the ratio to baseline of the maximum walking distance, as well as a number of confirmatory secondary endpoints. And the study results, again, you have already seen presented to you, and this is straight out of the Lancet paper, with the median maximum walking distance at 52 weeks shown on your left, the median maximum walking distance at 57 weeks shown on the top, and then the median pain-free walking distance at week 52 shown on the top right. And then in the box, the supportive or exploratory outcomes, and the treatment difference. So the difference between the treatments, I should say, is what's listed for you there. So this is just a quick recap of that, which we've already learned. So the question is, what are the key takeaways as an endocrinologist/diabetologist? And I'm going to present to you 5 of the key takeaways that I've taken away from the STRIDE study. So first and foremost is this one. Don't forget about peripheral arterial disease. And we heard from Dr. Al-Balawi, wonderful lecture reminding us about the epidemiology, about the implications, about the complications, about the morbidity and the mortality associated with the presence of peripheral arterial disease in those living with type 2 diabetes. And for the longest time, we talked about microvascular complications. Then we focused hugely on macrovascular complications, particularly atherosclerotic cardiovascular disease. Then there was a shift to heart failure, and we forgot to talk about peripheral arterial disease. And I'm hoping with the STRIDE study that this represents a shift as a bit of a reminder, hey, don't forget about me. Peripheral arterial disease is very real in our patients living with type 2 diabetes, and has also been mentioned by our speakers, the fact that the onset is insidious and slow. People slowly start to do less things than they were doing before. So they're not necessarily coming in complaining to you about such, and if we don't ask the right questions, we will not find these individuals. And then on top of that, doing the appropriate testing, which would be the ankle brachial index. Now, this is not something I can do in my office. I do not have the equipment to do it. So knowing where in your local region you could refer someone to get the ABI done is another important takeaway I want all of you have from today. Key takeaway number 2 is around safety. So you're probably looking at it going, safety? What do you mean safety? We already have well-established safety when it comes to the GLP-1 receptor agonist class, and specifically around semaglutide. But I want to point out to you that STRIDE interestingly studied a population that was not typically studied in the GLP-1 studies that we are used to. So what do I mean by that? Let's start off from an A1C perspective. This is a study in those living with diabetes. And here, the mean A1C was 7% in the sema group and 7.2% in the placebo group, which is sort of lower than what we're used to in semaglutide diabetes studies. The next one is the BMI. So I have here the median BMI, 28.7, 28.5, and then the percent of individuals with a BMI under 30 was actually the majority. The majority of people in STRIDE had a BMI below 30. A lot of the other outcome studies in the GLP-1 space and semaglutide are in those with BMIs over 30. Here, the majority were under 30. And then finally, a good amount of use of SGLT2 inhibitors, 37%, 33% at baseline. What happened to the A1C? The A1C came down, more so in the semaglutide group, obviously, compared to the placebo group, in a group that did not need a lot of A1C lowering, but this is something that I think clinically we see. And then from a body weight perspective, there was reduction in body weight, about 6% in the semaglutide group, and even the placebo group had a little bit of weight loss, but not a tremendous amount of weight loss, which is a good thing when the majority of people had a BMI under 30. But the reason I want to point this out, though, is because one of the major concerns, and still continues to grumble at various conferences, is this question about sarcopenia. Is this question about, if we use these therapies, particularly in people whose BMIs are not that high, are we actually going to cause problems with them from a sarcopenia perspective? Now, why do we care about sarcopenia? We care about sarcopenia because that will reflect functionally in terms of what people are able to do. But as you already heard in the STRIDE study, it was a functional outcome study, and people's functions got better. So even though the majority of people had a BMI below 30, and yes, they lost weight, they actually were functionally better than they were before. So I think this gives me confidence, and this gives me reassurance that when used properly, this is not something that I need to be that worried about. I think the third key takeaway is around the role of GLP-1 receptor agonists and atherosclerosis. So STRIDE showed greater improvement in the ABI in the semaglutide group. Now, I'm going to steal this from Dr. Verma. And in fact, he already showed this in his presentation. This is a beautiful figure, Subodh. Whoever drew it, they should get kudos for it. But it's a beautiful figure, and it very nicely outlines all the possible mechanisms through which GLP-1 receptor agonists can result in the benefits seen in peripheral arterial disease. And I think there's still a lot more work to be done to better understand the mechanistics around this. But I think this is a reminder in the STRIDE study, PAD being a very atherosclerotic-based disease, the role of GLP-1 receptor agonists and the role of being anti-inflammatory in the context. And then the fourth takeaway is the importance of functional outcome studies. So yesterday in the debate, John Purnell was saying how as an endocrinologist, we were not bound by the limitations of evidence, and that we could sort of look beyond evidence and look at the larger person and the holistic, but I think in the last number of years, because of the wonderful cardiovascular outcome trials and renal outcome trials, I think we've started to become very wanting of hard outcomes. And I still agree. And I would say in this space, we still need hard outcomes, but let's not forget the importance of functional outcomes. So functional outcomes, how are they defined? So a measurable result that reflects a person's ability to perform activities that are important for daily living. To assess how well an intervention helps someone regain or improve their ability to function in everyday life. And they are meant to be practical, patient-centered, and measurable. Our patients care more about functional outcomes than they do about hard outcomes. We probably care more about hard outcomes than functional outcomes, but then who are we serving? We're serving our patients. So I think we really need to remember that functional outcomes are very important for us to still be looking at. So this is supposedly a picture from Google of somebody walking on a treadmill at a 12% incline. And up here in the box, again, I'm reminding you the maximum walking distance improvement, the pain-free walking distance improvement, whether it be median or mean. I'm going to take that 39.9 meter mean absolute improvement and translate it into feet. Canada's an interesting country. We are mostly SI units, but not when it comes to distance and height and weight, right? We tend to use feet and pounds when it comes to height and weight. It's very confusing. So I've just translated it for the entire audience. So we've got 40 meters and about 131 feet. But that is on a 12% incline, walking at 3.2 kilometers per hour or 2 miles per hour. So this is kind of what it would look like if they were to sort of map out the 131 feet at a 12% incline. So if everybody wants to turn to the back of this room, as I was sitting up here, I was thinking what that would mean. That would mean going from that bottom corner of that room and walking up steeply to where that hangover is over that door. That's about 17 feet, perhaps a little bit higher than that. That's the grading that the people can now walk up at 3.2 kilometers an hour, which is a pretty brisk walk. And that is on the graded, and then as we've been told, we can double it for the flat, which means being able to walk from this particular symposium room out of the convention center, which we all need to do at some point later today. So I think this just gives you a concept of about what that means. But what that means for the person living with PAD is perhaps being able to make it to their mailbox, which may be further down the block, being able to walk farther with their family members in the park, or being able to get from the mall to their car and having the ability to park their car a little bit further. Like it means something to people. But the other beautiful thing is there wasn't a plateau. This was 52 weeks, right? So in theory, if this were to continue, I'm an optimist, this is probably going to continue to improve, which means people are going to be happier and being able to do things that you and I take for granted. Now, for the ladies in the room who wear heels and for the men in the room who like to wear tight shoes, you do know what it means to walk with pain. It's a different kind of pain, But at least, picturing yourself walking from this symposium to out the door when you're in pain, I think there are things we take for granted, and I think just being able to walk is one of the things we take very much for granted. But for someone living with PAD, this means a lot. And the other reason why I think this is important is in the world of sort of risk literacy, science literacy, health literacy, this is just a definition of what these different literacies are. But back to the point I made earlier, patients do not care about, I'm going to reduce heart attacks, strokes, and death. You would think people do, but it's an abstract concept of me having a heart attack or me having a stroke. It's a little abstract, but I can walk farther without pain. Okay, that's something I can feel soon. And I think that has a lot more meaning to people. And then in fact, the Society for Vascular Medicine put out research priorities, and research priority number 4 and number 5, and they had a long list of research priorities, was actually identifying therapies that prevent MACE in male in PAD, and identify medical therapies that treat walking disability. So it is a priority for the vascular community to actually create studies like this. And then the final takeaway is that this adds to the abundance of evidence we already have when it comes to GLP-1 receptor agonists, and specifically semaglutide. So we have these studies looking at different kind of outcomes in people living with type 2 diabetes, and then we can add to this now the PAD story. And then if we look at in the totality of evidence in terms of GLP-1 receptor agonists and the outcome benefits that they bring, we've seen this meta-analysis before, 3-point MACE reduction, cardiovascular death reduction, fatal, non-fatal MI, fatal, non-fatal stroke, all-cause mortality, hospitalization for heart failure. So we already have 1,000,001 reasons to be using GLP-1 receptor agonists in our individuals living with type 2 diabetes. But I think what STRIDE does is it reminds us of these other important things to take away. And also, I think, reminds us about peripheral arterial disease in this population, and yet another reason why we should be thinking about these therapies. So the 5 key takeaways: peripheral arterial disease, please don't forget. We need to be asking about it, examining for it, and measuring ankle brachial indices. The safety of semaglutide in older, frailer individuals with functional capacity limitations with a median BMI of only 28, showing functional improvement and not so much the sarcopenia story. Supporting the role of semaglutide in reducing atherosclerosis, the value of functional outcome measures, and finally adding to the totality of evidence for use of GLP-1s in type 2 diabetes. But there's a but. What else needs to happen? And Dr. Verma alluded to this already. I do still want to see hard outcomes, right? It's wonderful to have these functional outcomes. I'm still going to continue to use GLP-1 receptor agonists. This is still something that will help me convince patients to use these therapies, but I would love to be able to still see hard outcomes to then really transform guidelines and I think make that recommendation even stronger. So thank you very much for your kind attention, and we can open it up for conversation. So at this point, I invite people to the microphones and to ask questions of any of us up here. And actually, maybe while you're going to the microphone, I'm going to take the chair's prerogative, even though I didn't know I was going to be chair, but I'm going to take the prerogative now. And I'm actually going to start by asking Zaina a question. In the analysis that you showed from ICES from Ontario, you made the point there was that what seems counterintuitive, but I think I have an idea in my head why the places with, I'm going to get this straight, that had less diabetes and PAD had more amputations, right? And then the regions where there was more diabetes and PAD had less amputations. So you got that right, Zaina? So what are your thoughts as to why that was?
Excellent observation. I didn't touch on it. The authors themselves didn't elaborate specifically on it, and I think it was a bit of a surprise over there. So we're not sure, and I think when you look at they used administrative database and some validated codes to capture those diagnoses and outcomes, and they did, in their limitations, highlight that we don't really have, perhaps we've missed some of the peripheral arterial disease, just where there is a preclinical state. And in that study, they could not distinguish between severe, non-severe, and the grading of peripheral arterial disease. So The study aimed to look at a different outcome, and I think that was a bit of a surprise. But yeah, it was surprisingly, I think, quite lower, where you would have expected it to be at the top for those with diabetes and peripheral arterial disease and the amputations from the recent systematic reviews. So I don't have a good answer as to why that was there, but it could be related to the limitation of administrative database analyses and the ICD 9 and 10 codes that were available for it.
And I mean, my thought may be simplistic, but I was thinking that if they're labeled as having PAD, then someone's found it. And if you find it, you do something about it. But then if they're not labeled as having PAD, they have it, but you didn't find it, you didn't label it, you didn't do anything about it, maybe they're the ones with more amputation. I just made that up. We'll see if that's true. Okay, let's start over there. So if you could identify yourself and where you are working.
My name is Mehul Bora. I'm endocrinologist, private practice in Chicago area. Very excellent study. I'm thankful for giving us another indication, probably in the future, from the insurance company to get these medicine approved. I just had an observation during Subodh sir's slides. Smoking. So there were 29% people with smoking, active smoking. Was there any follow-up for them when they were on the semaglutide? If they had a change in behavior of maybe cutting down the smoking, which may have helped the peripheral vascular disease? I was just trying to understand because.
So first of all, thank you for your kind comments. We're grateful for those. Those data in terms of rates of smoking and the smoking sub-study will be presented at a meeting hopefully later on this year.
Oh, so stay tuned. So that's suggesting it did help, but I'm going to make that up. Go ahead. Actually, no, sorry. Let's go over here, please.
Asad from Alexandria, Egypt. Great talks, thank you. We are all aware about the recent publication in New England Journal of Medicine that semaglutide, although it was 2.4 milligram, improved the osteoarthritic pain in the knee. So can this affect the functional ability in this study? You are getting my points. I mean, can this improvement due to the improvement in the osteoarthritic pain rather than the vascular improvement?
So just to clarify, the Step 9 study, right, demonstrating the improvement in the WOMAC score for osteoarthritis.
This was on the
semaglutide. So the question is whether could some of this improvement have been related to an improvement in osteoarthritis? But I thought that other limitations were excluded. So please, Subodh.
So well, thank you for, again, I don't know that study in a lot of detail, and maybe we'll get Netta's comments there as well. The fact that we found an improvement in ankle brachial indices really speaks to a hemodynamic effect. Now, of course, you know, at the end of the day, many of these outcomes are multifaceted and multifactorial, right? So what we're trying to do at this point is slowly trying to eliminate. We don't think it was A1C, as Netta showed you. I don't think it's weight. It wasn't restricted to people with obesity per se. It wasn't SGLT2. And the fact that there's a hemodynamic improvement and an improvement in ABI, I think really points towards a sort of vascular hemodynamic benefit of the drug. But of course, improvement in osteoarthritis can only improve these outcomes further. But we did exclude people who had fairly advanced osteoarthritis and were unable to do that at baseline. And furthermore, you know, again, most of the OA, whatever the baseline arthritis, you know, although the trial was relatively small in terms of, you know, those things would be balanced between groups. Netta?
Yeah, I just want to reemphasize the last comment that part of the eligibility of a STRIDE was excluding people who had functional impairment to other factors, non-factor, if they had a spinal stenosis or they had CHF or some other factor contributing to this functional impairment, they were excluded. We tried to find patients that only the impairment was due to PAD, but it's very difficult to exclude that hypothesis.
Okay, thank you.
Please.
I'm Dr. Sunil Gupta from India. Congratulations, everyone. That's very important 2-3 points if you can just clarify. One is about the ABI. Have you calculated the ABI pre and the post, and what was the difference? I'm sorry if I missed out this point in all the studies, because we are focusing more on claudication distance and the pain threshold, and it has come a statistically significant difference. But was there a difference in the ankle brachial index? One, did we have a pilot study for a small number of patients subjecting for angiography pre and the post? And yeah, these two important points.
Okay, great. So it was around ABI, what was the actual difference? And then whether there was any angiography that was done to actually look, or and if not, if you're thinking about it.
I'm terribly sorry. There's a bit of echo sitting here, so I apologize if I don't get all the question. But the improvement in ABI was statistically significant. As you know, at baseline, it was 0.75 or 0.79, and that went up to, I think the mean increase was around to 0.81 or 0.82 or 10% in that regard. So that was, again, completely unanticipated, right? You would agree that a hemodynamic benefit over a short term is not something that you would expect. So we, and your second point, was there, studies done, sort of invasive cath studies? Or?
Yeah.
No, we didn't have any of those.
I'm sorry if just the cutoff of ABI taken is between 0.7 to 1, right?
So
anyone,
the ABI of less
inclusion
than
criteria,
0.9 or
0.9.
Sorry, 0.9 to 0.7, 0.7 to 0.9.
TBI was 0.7. For ABI, anybody who had ABI less than 0.9 would have been eligible.
Even 0.5, 0.4 have been taken, or up to 0.7.
0.7 was for TBI, toe brachial
okay,
index.
Yeah. Okay, thank you much.
Great, thank you.
Please.
Can you hear me? My question for Dr. Chang. So my name is Abdullah Malham. I'm an endocrine fellow at Loyola University. I attended your debate yesterday about choosing between GLP-1 and SGLT2 inhibitor, and I would say you did a really good job trying to defend the SGLT2 inhibitors. The question was, I think the initial studies for the SGLT2 inhibitors, the CANVAS studies, showed increased risk of PAD and acute limb ischemia for the canagliflozin. Do we still believe that SGLT2 inhibitors worsen PAD? And in this study, did you guys found that people on SGLT2 inhibitors, did they have a different response than people who are not on SGLT2 inhibitor?
So maybe I'll take the first part, and then Nita, you can answer about the subgroup analysis. So in terms of that, so first of all, when you do a debate, you're assigned a topic, and then your job is to take the evidence, massage it in a way so that it fits whatever you need to say. So that's my point number one. Number two is, so it was the CANVAS study that was, there was a suggestion about canagliflozin and the increase in lower limb amputation, which was not shown again, whether it was in credence with sicker population using canagliflozin or in any of the other SGLT2 inhibitor studies. And if anything, there was, as we already know, the reduction in MACE and some suggestion of really actually particularly more improvements in those with peripheral arterial disease history, because they're often multivascular paths. So therefore, the SGLT2 inhibitors I'm very comfortable using in people with peripheral arterial disease, and I continue to use in people with peripheral arterial disease. And for a while, I would get referrals from vascular surgeons of someone who was actively admitted to hospital, but their infection was already clearing, and they had significant PAD, and they were wondering, should we still use an SGLT2 inhibitor? And in my mind, the answer was yes, because it was about their overall vascular health, and then also being able to prevent the amputations, because we understand the importance of proper foot care. So to me, the answer is yes, I absolutely will use SGLT2 inhibitors in people with PAD, and almost preferentially so because their absolute benefit is actually going to be greater because their absolute risk is so high. But in terms of within the context of the study, Nita?
I showed the data that about 35% of population in STRIDE cohort, they were on SGLT2 at baseline. So when we added GLP-1 on top of SGLT2, the benefit of semaglutide and functional capacity was consistent. We have data on MACE reduction for SGLT2 inhibitor, but we don't have any data on their effect on functional capacity or anything. So I don't know if I understood your question. Just repeated my finding that it was...
Like people on GLP-1 and just GLP-1, did they have better response than people who were on GLP-1 and SGLT2 inhibitors?
We know that the response was not different on SGLT2 in the background or without SGLT2, similar level of beneficial effect with semaglutide.
Thank you.
Good evening. I'm Dr. Ghanem, Alexandria University, Egypt. I have two inquiries. After the STRIDE study, do you believe that this is a class effect or semaglutide effect? This is my first question. My second question for the surgeon. You showed us elegantly the results in type 2 diabetes. Do you believe, can you use it in the general population? Thank you very much.
Excellent question. So first question, is this a class effect? You get this question all the time. Is this a class effect? Who wants to take this? Subodh.
Well, I don't answer that first question. I'll hand it back to you. But you know, I think it's a good point. You know, I think we will just have to wait and see as other trials evaluate. You know,
there were other GLP-1 receptor agonists used in other trials, and this is the first one to show peripheral vascular disease.
That is true.
Patients with type 2 diabetes with long duration. What about the second question?
So the second question also, you know, is a very important one, needs to be answered either in a functional study or in a larger study, because as I mentioned, the morphology and anatomy of people with PAD without diabetes is different. But you know, I don't suspect, if I had to guess, I would suspect that the benefits will be consistent in both, because remember, you know, people with diabetes also develop diffuse coronary disease, right? And in the trials like SUSTAIN-6 or SELECT, which represent the diabetes and the non-diabetes spectrum, the benefits are really agnostic to the presence or absence of diabetes from a MACE standpoint. So I would think that they would be the same, but the trial needs to be done.
Any other questions from the audience? I did want to give Zaina a chance, though, to answer about the SGLT2 inhibitor piece, because I know that you run clinic very much focused on feet. So what do you do in that practice? And then if there's no other questions, I'll then wrap up. Go ahead.
Yeah, so I think when the Canvas study came out, we all had quite a concern, and you know, we were sharing with patients that possible association, but still waiting for some of the subsequent trials. And most people, I would say, and this was very biased to the population that I worked in when I was in Alberta in a high-risk diabetes foot clinic, most of them actually opted to go off SGLT2, and this was in the very early days. But I think since then we've had substantial data, and even looking at other higher risk populations where this particular signal has not been replicated. We don't fully understand what happened with Canvas or why that was there. There were, of course, a number of theories and hypotheses. But in higher risk trials like the FLOW and individuals with chronic kidney disease, we haven't really seen, we haven't seen a replication even in those with higher risk. But I guess one of the limitations is we all hope that it extended a little bit longer for SGLT2 inhibitors in the chronic kidney disease population. So I would say, you know, the verdict is out. It's unlikely that it causes lower limb amputations, and similarly, I use it liberally, and I no longer, you know, counsel individuals on it because I don't think it's a significant effect and hasn't been shown in much higher risk groups subsequently.
Please.
Hi, I wonder if you could share what data prompted you to look at the effect of semaglutide on peripheral artery disease. Were there data that suggested that it could be effective? Was it just a matter of try it and see? I wonder if you had any insights.
So the question is around the rationale. Why ask the question?
No, it's a great point. So in terms of prior data, there were some data with liraglutide that actually suggested a reduction in amputations. That was the basis of it. And I think it was the accumulating biology of sort of an anti-atherosclerotic vascular medication. And also, I would say the third point is the really quite robust anti-inflammatory signal that is seen with these agents. And again, you may be aware, but of all of the various arterial beds, the natural history and progression of PAD seems to be exquisitely sensitive to inflammation. And, smoking and inflammation tend to be sort of the main drivers of progression of disease there. So that was the hypothesis. This was building coincident with the other concept around the HEF-PEF story, that it will improve functional outcomes. And I think those two hypotheses, while they were going in parallel, there was a little bit of overlap, thinking that functional capacity may improve even in people with PAD.
Thank you.
Okay, so sorry, another question, please.
Thank you for these great lectures. I have a question regarding the outcomes. I think it's on our minds and our patient. What about the role of Doppler if you are assessing the outcome? Because sometimes junior staff, even patient, ask about if there can be like imaging improvement in this after this molecule. I know about the history, the free walking distance, but what about the visualized outcome? It can be, or there's ongoing studies for the Doppler effect, arterial Doppler, I mean.
Again, it's hard to hear up here, but I think the question was around whether there was an imaging difference in imaging.
Imaging which illustrate the outcome after this molecule, after implementation of these guidelines with the patient. Can we have a study ongoing to see what's happening in the, as you said, the metabolic profile for the patient, the atherogenesis process, the arterial Doppler can be a tool for follow-up or improvement, or there is any ongoing studies?
So use of arterial Dopplers and other modalities to...
Before and after, yes.
Before and after.
Yes. Any data?
So kind of, you're asking whether we can do more mechanistic study to find out why...
Yes, because according to the outcome, it's a little bit subjective because you are talking with the patient to how many stand he can stand distance and what's improvement. But what about the actual improvement, like the echo in the SGLT2 or the function of the heart?
So the question was, the primary outcome was the functional improvement in the functional impairment, and it was questionnaire and subjective. Yes. What about the objective outcome? And what we had ABI that improved before and after. So we have some sort of a kind of objective.
No ongoing studies by the Doppler, or is that like other molecules checking the arterial thickness before and after? There's no ongoing even studies for the role of the Doppler in assessing the improvement?
No, I think I get the gist of what you're saying. And again, our apologies. There's a bit of an echo here, so I'm sorry if we're not answering your question. But, first of all, the measure that was used as the primary endpoint was guided very closely with regulatory and guideline-based discussions, right? This is not an outcome to be taken lightly to say, how much do you walk, what's going on, is it a bit more or less? Because exactly what you said could become a concern, right? Because it may become loosey-goosey, like what is this? A constant treadmill, incline is sort of a very robust way of assessing this outcome, and is actually, that's exactly why it was done this way. Furthermore, the reason why we included people with the so-called unusual definition of Fontan 2A as opposed to the Rutherford classification is we wanted to take away any subjectivity from that definition and put quantitative measures to say we define claudication based on this distance and that maximum distance. And you've got to color within the lines on an objective way if we want to assess it. So two of your points, I think, are very important to reiterate. So thank you for that. The point around hemodynamic improvements and further assessing that is what we tried to assess carefully with ABI. And I think while that was a lower down in the hierarchy of things that we tested, I think that's very, very important to provide reassurance that these benefits are real and hemodynamically driven. And finally, as you'll see in the Lancet paper, they actually they were asking the same question that you are, and that is, tell us about the natural progression. Where is this going? When the rubber hits the road in the trenches, what does this mean? So while it was exploratory, the exploratory outcome of intensification of treatment, all-cause mortality, major adverse limb events, the ones that remain important to the doctors and clinicians, that was reduced markedly, right? So that tells us that you're moving the natural history in the right direction, and you'll need a larger trial to be able to confirm whether those point estimates or not. And this is not in isolation. SOUL and FLOW and other trials where male outcomes have been tested in larger studies are consistent with it. So I think the thesis that GLP-1 RAs are evolving as vascular medications for PAD, I think the writing is on the wall, right? It just is now a matter of us filling in some of those gaps, as Alice mentioned nicely, with larger trials, as Netta mentioned, with trials without PAD, looking at male outcomes. And I think that will be, it's been 25 years since the field has seen anything like this, right? So I think it is it's really welcome from our patients.
Thank you so much.
Okay, so with that, I'd like to, on behalf of the audience, thank our speakers for their excellent presentations.